All right, I think we'll get going again. My apologies. Just gonna look at that. Always want to do that. I'm doing that. There are people at the back, I think, who talk even more than I do. So I'm going to start again. I'm sorry for being slow in getting going. I've been enjoying conversations with people. Just give people a second to take their seats. Okay, so following on from Jason's talk and some of the points I was making earlier and some of the great conversations I've been enjoying with people, this is a sort of bit of a whistle-stop tour of a piece of work that we've been working on for quite a long time, and I'll tell you a bit about that, to develop what we initially called a checklist that we thought was about trying to work out with cancer nurses, what is it that makes a person with a cancer diagnosis complex to care for? So that's where we came from. So, but I won't do the acknowledgement again, but Jason's really talked to this, but I just want to bring back some of the stuff that Jason said, just to sort of put into context and remind ourselves of some of the things he talked about. So he said patients are different, and I'll talk about that in the context of what we've been trying to do. So remembering that the patients are different. Barriers to timely access and diagnosis is critical in terms of equitable outcomes to care. And people who present with comorbid disease are much less likely to have optimal health outcomes. Things we know, but they are things that we, on the whole, are not good at recording and then taking account of when we plan and deliver care to people. So I just wanted to sort of start by that sort of patients are different. And I was scribbling down when Jason talking, but how do we capture this? How do we show the contribution of nurses through capturing data so that we can inform the system when people are different? Because it's the people who are most different are the ones often who have the greatest capacity to benefit from the care that you provide. Right, so people like me who will walk into, Lord forbid, walk into a cancer centre and go, nobody's asked me about my supportive care needs. I need some holistic needs assessment, please. And, so I'll be fine, right? Because I can navigate the system. I can ring the head of cancer surgery and go, Sandy, can you fit me in tomorrow, please? Right? So I'm there. But the question for us is, how do we capture data in the context of this talk that allows us to inform the system to show what happens when you have cancer nurses picking up those patients who are different? Not the easy ones, who can advocate, who will get the care, who will get the trials, who will have the mobile number of the specialist nurse to call day or night, or the head of surgery, or whoever it may be. So how do we get the data to advocate for those patients that Jason talked about and all the other patients that we know about, regional, rural, isolated, those people talked about? How do we get the data to advocate for those patients? Because moving the dial forward for the likes of me and us is not equity. In fact, what it does is it actually creates more inequity because I get better and better and better care, and the people who don't have the same opportunity to do that fall further and further and further behind. And more of the resources go to this. Now, just while I'm blathering on about stuff, patient-reported outcomes. Now, some of you, may be familiar with this. There's a growing international evidence publication based on, it's all about patient-reported outcome measures. We've all got to have PROMs in the system, and we've all got to collect PROMs. We've got to use PROMs to build new models of care and know where we need to put the money. Who do you think is not in that PROMs data set? It's all the people that Jason talked about. It's the people with health literacy issues, preferred language, not English, regional and rural, socio-demographically disadvantaged. They're not in the PROMs databases. So if we build our health systems and our models of care on the amazing PROMs, assuming, of course, that you have 50 people sitting in the background just waiting for the PROMs data to come in so you can look at it and feed it back to the team straight away, because otherwise what you're doing is having PROMs data coming into the system that nobody has the capacity to respond to or look at, and that's unethical. So it's just when people talk to you about PROMs, there are two reasons for PROMs. One, collecting data for big data sets, which is fine. You don't need somebody looking at that straight away. But those data sets will be deficient in the people that we're concerned about. Or you have PROMs data to inform practice, right? So real-time response, like we did in the pancreas work. But if you haven't got the capacity to look at that data in real time, what you're doing is you're asking patients to tell you what's wrong with them, and then there's no visibility on that data. So always be, of course they have a place, of course they do, and they standardize measurement and they do give us databases, but really important to remember that. So people are different, and PROMS data is no different to that. And so when you think about the articulation of PROMS data to AI, algorithms, predictive capability, so we keep building our system on white, affluent, middle class, health literate people. So anyway, enough about that. Makes me twitch. Okay, right. So the thing that Jason was talking about, we need data to advocate for patients. And the quote he put up was, different resourcing is needed in order that different groups enjoy equitable health outcomes. So the question for us is, how do we do that as nurses? So I've left that up there long enough, so I'm going to move forward. So this is an amazing group of people, apart from Holly, who refuses to have a photo taken. So Holly's there. So Holly, Amelia, Sancha, Carla, and Liz. So these are my colleagues who've been working with me on this piece of work for 12 years, maybe. But Sancha's a nurse, Liz is a nurse, Niels is an epidemiologist, Carla's the most amazing healthcare statistician, unbelievable, looks at any set of data and go, where are the patients in this? Amazing. And Holly is a new PhD epidemiologist who's a rising star, and I must link her with Jason. Anyway, so what we were really sort of exercised about good decade ago was that, you know, we know that every person who interacts with the health system interacts with the nurse, every single patient. So how do we mobilize our potential? Every interaction between a nurse and a patient and the whānau is an opportunity to address inequity, that we actively, unapologetically look for inequity in every patient that comes into our care. Nursing's contribution to and role in addressing inequity is overlooked. The biggest health workforce, and we are overlooked. It is deemed to be the business of amazing people like Jason, thankfully, but actually, where's the translational capability? How do we have the benefit of somebody like Jason enable us to actually do something in practice? There are over 20 million of us worldwide. So why can we not be used to our advantage, our skill and capability to address this stuff? So we started back before 2010, but this was the first sort of real study. It was funded with $3,000 from the Cancer Nurses Society of Australia. It's been a labour of love. And we set out to ask 100 cancer nurses across Australia, what makes a person with cancer complex to care for? And when we'd got through things like multiple appointments and car parking, and we said, no. Those are system issues. What is it about the people that makes you think when you look at somebody, this person's going to have complex care needs? And I'll talk about both in a moment. Qualitative data, lots of focus groups. And what came out after we analysed all that data was a really rough draft of a checklist. What would be the things that you would think, oh, yeah, it's going to be that, and that. And then we sent the draft checklist back to the people, the 100 nurses, about 5 or 6 times. We kept changing it. They kept sending us feedback and through surveys, and we recorded all of that. And then we were able to move on. I'll talk a bit more about this. Don't worry about not seeing this for the moment. I'll talk a bit more about that. We then, once we had the final draft, and it literally took us about 15 drafts, we sent it out to 50 cancer nurses across Australia and gave them 3 hypothetical case studies of 3 patients. It said, can you test the checklist with these patients? Does it make sense? How long does it take you to complete? You know, does it seem to work? We had items taken out, we had new ones put in, we had some reworded. And then once we got to the end of that process, we had 10 nurses at Piramac work with real patients, 5 each. So we had 50, we had tested it with 50 people to see whether, one, was it easy for the nurses to use in the context of a real-time interaction with people? What were the patients' reactions to it? What did they think about having these questions asked to them? And what we heard was everybody liked it. It took a couple of minutes to complete, although the conversation that goes with it, of course, takes longer. But the actual checklist took a couple of minutes. But what we had done initially was we'd given every one of these items a score. And then the patient said, well, if I have a score of 15 and he has a score of 2, but his 2 is more damaging than my score of 15, what does that mean? And we went, nasty. So we just dropped the score and thought we're going to leave that. So because actually to do that well, you'd need hundreds, if not thousands of patients, and then do some psychometric testing and look at predictive capability. And Carla could have done all of that for us. But actually, we thought, actually, does it matter? Does it matter what score somebody has? Because then the risk is you start making decisions about who gets care based on a score. It's like quality of life. I've got a quality of life of 60. What's yours? You know, meaningless. Right? So we dropped the scoring and decided that if people have one item on here and it's a potential risk for them in terms of their ability to have the best care possible, that's enough. So what we learned through from looking at the data, listening to patients, talking to the nurses, is that the complexity checklist, as we've been calling it, was not so much about complex care needs. It was actually about social determinants of health. There was some medical stuff in there, but it was largely about social determinants of health. So that, not the proximal stuff that Jason talked about, although there are obviously medical things in there, not the obesity and the diabetes, although they're there. It was poverty, rurality, insecure housing, homelessness, all the things here. What early childhood development issues, nutrition, access to food, all those things that were enormous. And so we sat there and went, really, is this the business of nurses? And what can we do about all of that? And we said, well, we can't fix it. But if we turn a blind eye to it, it doesn't matter how clever our immunotherapy drugs are going to be. These people are not going to do well. So how do we know about them? How do we find them? How do we give them a visibility, a voice, a data set in the system that allows us from the first time they come into the system to go, these people are going to need more. So that issue of different resourcing, these people are going to need more, whether it's more information, different kinds of information, more referrals, contact more often, whatever it may be. But we know from a social justice point of view, if we overlook these people, they may have curable cancers, but they may die because they just won't be able to come back for treatment or whatever it is, or they won't know how to take the medicines. So, we said, well, actually, how important is it? How important is it to address these social determinants? Now, there are loads of studies. This is data reported by the WHO. 30 to 55% of health outcomes are determined by social determinants of health. That's huge. And so if we can get to people early on, get them to social workers, get them to community groups, get them to support organizations from their culture or their background, these people will be diminished in that proportion because we know who they are. Right? We're hearing it all the time. I'm not going to read this. It's a fantastic piece from the WHO that defines why social determinants of health are important, because it accelerates our progress towards health equity. So equity is today's theme with advanced practice. If we turn a blind eye to social determinants and decide that it's not the business of nurses, we will not contribute to accelerating our movement towards health equity. So I was thinking, well, actually, why then is it so important for us as nurses? And if it is important, what on earth can we do about it? On top of the 50 bazillion of the things you're doing all day, how do you suddenly take account of social determinants of health? But look at this third recommendation from the WHO issues around their document of Commission on Social Determinants of Health. Take steps to measure and understand the problem and assess the impact of action. And so for us as a team, we went, that's it. That's where we sit. How do we take this complexity checklist and use it to start measuring, understanding what is the magnitude of the problem? How many of our patients that we care for every day are compounded by social determinants of health? Because actually, if you build that data over time, and what we're hoping to do with the checklist is in 5 years, we will have a really big data set that we can say, look at these outcomes by social determinants in a way that from a nursing database that we've never been able to do. So that's what we're trying to get to. And then this happened. We tried to get funding to move the work on. If Jason thinks equity isn't cool now, it absolutely wasn't from a funding point of view back in Australia, back in around 2010, 2010. We could not get this work funded for love nor money until we got to 2021. So that's a 12-year hiatus. There's a thing about nurses getting research money, but don't start me off. But anyway, there was this stuff around, we already know this stuff. No, actually you don't. We know it at that macro level, but we don't know what it means for people passing your biggest workforce day by day by day in a cancer context. So we went ahead and kept working with the checklist And we put it into, we got some money from Perpetual as part of a philanthropic grant, and we put it into a multidisciplinary context. We wanted to see, can you actually use this in a multidisciplinary context, in a cancer context? And does it actually help us find those people who are at risk? So, reminder, we designed the checklist to be used with and for with nurses for people who are at risk to support early and systematic identification. So lots of you will be doing this in lots of different ways. Lots of nurses already do it, but it's not done systematically. We don't have a data set, that measuring piece, so that we understand the magnitude of the problem. So we systematically wanted to identify people. It is different from things like supportive care needs screening tool and other ways of, because that was the other thing we were hearing from grant reviewers. Oh, we were already doing this. It's in the supportive care needs screening tool. The supportive care needs screening tool does not collect social determinants of health data. It is quite unique. There is nothing like it for nurses anywhere. We've looked through all the international evidence. So we keep saying to people, it's not about supportive care needs. It's about social determinants of health. You know, I've got supportive care needs. You know, if I was unfortunate to have a cancer diagnosis, I'm going to be scared. I'm going to be worried about what I say to my children. I'm going to be worried about the amount of time I'm going to have to take off work. But I don't have to worry about whether I've got a roof over my head, whether I can still feed my children, whether I can afford to get the treatment. They're quite different. So what we'd done in that sort of desert years where we were trying to get funded, we'd worked hard with a checklist. We made sure that each of the items on there, it's got 4 domains with 15 items on top of it, that each of them was aligned with evidence. Does this item have evidence to show it's aligned with a social determinant of health indicator? Does this item have evidence to show that is linked with a medical indicator of health outcomes? So we know that the items are evidence-based. We made sure that there were services that we could map each of those items to. There's no point saying to you, can you ask people if something's wrong, but there's nothing you can do about it. You know, so there was a sort of an ethical piece there about mapping them to services. And we really wanted to set it up in a way that you could put it into an online method of collecting the data so that we build an administrative data set. In 5 years' time, what does the makeup of people coming into hospital X, Y, or Z, or community centre X, Y, or Z look like from a social determinants of health perspective from the care that nurses deliver? And then we can start looking at outcomes and things like who with social determinants of health impact on around their cancer diagnosis does better when they have a cancer nurse involved in their care. We can't do that now, but if we do this, we'll be able to do it. So this is what it looks like, and it'll change again. So this is not perfect, it's the beginning. It's got, these are 2, I'll put the other 2 on the next slide. This is, and if you want a copy, happy to send it to you. So you can see all these things that fell out from the beginning: social support, living arrangements, distance from treatment, toxicities, called background, Indigenous background, all these things that have to do with social determinants of health. And then there was a couple of things around disease status, so advanced disease diagnosis. Absolutely imperative for our First Nations people, from whether they're Maori or whether they're Aboriginal and Torres Strait Islander, because we know they tend to present with more advanced disease often, not because they genetically have more advanced disease, but because they have access issues to get into the system. And that's the same for people who are isolated and lonely and poor and all those things. And people who have really complex diagnostic pathways. So you think about the optimal care pathway. You know, you come into the pathway and you are meant to have your diagnosis in 3 weeks, you start treatment 2 weeks after that. What happens if it takes you 6 weeks to get a diagnosis, 7 weeks to get a diagnosis? You never have a diagnosis, you have a cancer of an unknown primary. So, you know, there are problems with these kinds of things. And then the last 2 domains, health status and symptomatology. So this again comes back to some of those proximal determinants of health, things like obesity, substance abuse, sedentary lifestyle, smoking cessation, florid mental health, really complex mental health issues. And then this stuff around uncontrolled symptoms. And a number of us were talking about the power and value of nursing with those emergent symptoms. Sorry, what was that? Tell me that again. What did you say about that? And you can go, hang on a minute. So, you know, this stuff about why do you need cancer nurses with knowledge and skills? Because you need the radars, right? You need to hear that one word and go, what do you mean you've got pins and needles in your hand? When did that start? Yeah. So it's a very simple 1 side of A4 checklist that can be completed in a couple of minutes, literally 3 minutes. But of course, as with any checklist, power and the values in the conversation, right? So we're not saying it's a standalone thing, but nurses loved it, patients love it. And one of the first things one of the patients said to me in the study was, what do you mean you don't ask people these questions all the time? Sorry. This is, I'm not going to talk to this, but this is the structure of the clinical utility study. It's in the paper if you want to see it. We had nurses trained to use a checklist, so there was standardization. That literally took about 10 minutes. They went, yeah, whatever, we do this every day. So they said it was really easy to do. They'd complete the checklist with the patient. Then we interviewed the patient. Was that okay having somebody ask you those questions about whether you have money and whether all those things? Is this acceptable? Is it okay? And then we had medical record data on all of the patients who came into the study. We had 32 of them, and we followed them over time. So who of those patients who completed the checklist that entered the system went on to need quite a lot more help? And does this checklist, at a very high level, begin to give a pointer to those people? So it's not prognostic as yet. We'd need a much bigger study. But is there an indication that if we use this every day, we could start to build algorithms to identify those people that we need to get to from day one? In fact, preferably before day one. So we used lots of self-completed promise forms to be able to compare what were these validated measures of problems saying, and look to see how closely did that measure with the checklist to make sure that it was giving us accurate data. And I'll skip that. But what we found was that actually it did. It's a really nice way of beginning to introduce the conversation. And when we look at those things like appropriateness and disruption, these are the kinds of things we were hearing. The checklist sort of lets you ground yourself, allows you to know what you're looking for, to see if you're in the ballpark or out of the ballpark with what's happening to you. Nurses saying, I think it'll save time. I think to have a format, a checklist means you're not missing things. And we talked about that a couple of us earlier, but also from a point of view, if you've got junior staff coming in, it really helps structure their conversation. For those of us who've been doing it for years, it comes automatically. But how do we help that remarkable next generation of nurses coming through? I felt really comfortable, no problem. I think the reason was because she had the conversation with me. The wording's almost like they were saying, it's a bit stiff, the nurses were saying, when you use it, but you talk around it in your own way, but it does help standardize the conversation. And I just want to draw this out. The wording needs to be more around directing it at them to answer. How do you engage in that conversation? I'll come back to that. People here saying, one of the patients saying, one of the things that was missing for me, the person said, was you need to know if somebody's safe in their own home. If you notice on the checklist, there was nothing around domestic violence or safety at home, and we're putting that in. And then one of the nurses saying it's important to use tools like this when we're assessing patients. Having some wording also for staff is helpful, because going into some of these aspects of childhood development, whether you can put food on the table, they're not easy conversations, as we know. They need skill, they need sensitivity, and particularly when you're having them across different cultures and ethnicities. So we were able to show that it has promising acceptability, appropriateness, and practicability, but the people who took part in our study, surprise, surprise, this comes back to that PROMS comment, is they were largely white, health literate, English speaking, right? So just in the last couple of months, why does that matter for us, particularly in Australia, one of the most culturally and linguistically diverse countries in the world? Over 30% of our people are born overseas. So actually, to have a checklist that works for me is irrelevant. So what are we going on to do? I'm just going to whiz through these in the next 2 minutes. Is we were lucky enough to have money from Tour de Cure to carry out a cross-cultural validation of what we're now calling the NEAT. The patient said, can we not call it a checklist? It makes me feel like I'm a car, one gentleman said. So we said, okay, what do we call it? So this was the hardest part of the whole thing. You put 15 patients in a room and 10 nurses. It's like gunfight at the OK Corral, right? It was just, what are we going to call it? Anyway, the decision from the patients was it's a nursing equity assessment tool, the NEAT, which we thought was really cool. So we're now calling it the NEAT. And we're working through something called participatory action research, which is a really qualitative engagement methodology where we've gone to culturally and linguistically diverse communities and said, we've developed this checklist. What are the questions you think we should be asking about it? What would you want us to do with it? How do we develop the protocol for the research with you? And so we're doing that at the moment. Holly's leading it, just amazing work. So we've at the first phase had 5 patients, 5 healthcare professionals, just to begin that conversation of what the protocol should look like, what else needs to be in there. So saying you need to understand things like pre-migration experience, visa status, Medicare, Medicaid. None of this is in there. Right, so you can see who it was developed with and for. Right, so it's fantastic. So we're thinking about how we get this stuff now in, and some of the stuff we're putting in is familiarity with the healthcare system. Doesn't matter if you can get my diagnosis done in time. If I don't know how to get into the system, how to get back into the system, what I'm eligible for, what I'm not eligible for, it's not going to go well for me. We need something around familiarity, and we need something with, has anyone in your family done or said something that made you feel unsafe or afraid? So we're putting that in there as well. So, just fantastic. It's going to be following on from that early piece of work where we've developed the protocol with the community. We're now going into a qualitative interview study to ask these two questions. How do culturally and linguistically diverse cancer patients experience access to the system and navigation to the system once they're in? And what can we do as nurses to identify those barriers early so that we can intervene early using the NEAT? And then the last piece of work, and this is that one of the last two slides, is we're now thinking about how do we enable the workforce, the nursing workforce, to use the NEAT. So we're working with nurses in regional cancer centres to begin to think about how do we co-design with the nurses prompts around each of the items so that we're asking the questions in standardised way, so that we can develop videos and resources and case studies for how they might want to use the NEAT, that we can then map the NEAT to something called We Can, which is an online supportive care resource that we developed, again, and co-designed with patients, where you can go in, you can fill out the distress thermometer, the problem list, and go, these are my problems, this is my diagnosis, this is what I'm worried about. And then the We Can site collates all of these links that takes you to reputable resources and services for each of those problems, so that the nurses don't have to worry about where they go and find stuff. And as the NEAT gets finished, we'll build up the We Can to put in the new resources and referrals that we need. And then we're going to look at testing whether the resources are really, whether they work in practice for nurses. So in conclusion, we have a fantastic and actually, I think, an ethical opportunity here to think about what is our leadership role, not our contribution, but our leadership role to addressing inequities in the healthcare system. We are optimally situated to do this work and to work with our multidisciplinary colleagues to quickly identify, report, and get help to those people who most need it, those with the greatest capacity to benefit. And we have an opportunity to take an advocacy role, a leading advocacy role in targeting resources to those with the greatest needs. So not needs-based, those with the greatest needs, not all needs are equal. I'm just going to leave that there. If you want some resources on toolkits on social determinants of health or nursing, these are some fantastic ones from WHO, from the States and Canada, where they're doing amazing work, but also really happy to share the slides for those of you who might not get them. So I'm going to stop there. Thank you very much for your time.
Right, so next up we have Look Good, Feel Better General Manager Claire. Claire has been leading the cancer charity's passionate team of support staff and facilitators, volunteers for over 12 years. Through her guidance, it is shown to evolve and is now meeting the need of the people throughout New Zealand that are living with cancer.